Hello everyone, welcome to AETCM. I'm Dr. Bharat. Today we'll be covering Stevens-Johnson syndrome or toxic epidermal necrolysis as a part of our EM Rapid 2022 series. Through this talk, I'm trying to cover the basic introduction of the disease, the etiology and risk factors that cause this disease, clinical presentation of the patients, how to evaluate and diagnose such patients, what is the treatment that has to be given from an emergency medicine standpoint, what is the prognosis of the patient, and summarize that whatever we have learned through the talk. Coming to introduction of the disease, Stevens-Johnson syndrome and toxic epidermal necrolysis are severe mucocutaneous reactions, most commonly triggered by medications, and is characterized by extensive necrosis and detachment of the epidermis. Mucous membranes are affected in more than 90% of patients, usually at two or more sites, example like ocular, oral, and or genital. Stevens-Johnson syndrome and toxic epidermal necrolysis are considered as a disease continuum rather than two separate entities, and is distinguished chiefly by severity based upon the percentage of epidermis that is affected by blisters and erosions. Stevens-Johnson syndrome is the less severe condition of the two, in which skin detachment is less than 10% of the total body surface. Toxic epidermal necrolysis involves detachment more than 30% of body surface area, and between 10% to 30% is a overlap area which is called as Stevens-Johnson overlap syndrome. Now, in this talk, we will use Stevens-Johnson syndrome and toxic epidermal necrolysis together as SJS bar 10. Now, the incidence of Stevens-Johnson syndrome or toxic epidermal necrolysis is one of the rarest. It causes only 2 to 7 cases per million, and the incidence of SJS bar 10 is higher among active HIV patients or active cancer patients. It can occur at any age, but is predominantly seen in females rather than male at a ratio of 1:2. Overall mortality rate among patients with SJS10 is approximately 25%, ranging from 10% for SJS and up to 50% in 10. Mortality continues to be increasing up to a year after disease onset. That has to be kept in mind. Now, coming to the etiology of the SJS bar 10, the most common leading trigger is drugs, and its risk is usually within first 8 weeks of initiation of the treatment. Typical exposure period before onset of reaction can be as different as 4 days or up to 4 weeks of first continuous use of the drug. In 25 to 33% of cases, and even in higher proportion of pediatric cases, a drug that causes SJS or 10 cannot be singly identified, and history of previous tolerated use of suspected drugs can make their association with SJS bar 10 very unlikely. The following group of agents are one of the most common causative agents: for allopurinol, aromatic anti-seizure medications like lamotrigine, phenytoin, carbamazepine, antibacterials like antibacterial sulfonamides like sulfasalazine, nevirapine, and NSAIDs. In children, the medication most often associated with the SJS10 are sulfonamide, antimicrobials, phenobarbital, carbamazepine, and lamotrigine. A weak association with the acetaminophen or paracetamol has been reported, but it's not clinically proven. SJS10 is less likely attributable to penicillins, particularly amoxicillin or ampicillin. Several conventional and targeted anti-cancer therapies have been associated with this syndrome, including thalidomide, capecitabine, afatinib, vemurafenib, and tamoxifen. Coming to etiology of the disease, of infectious origin, Mycoplasma pneumoniae infection is one of the most common triggers usually seen in children. Cases have been reported. Other causes of SJS10 can be a manifestation after bone marrow transplantation. A manifestation of acute graft versus host disease can manifest like SJS10. Radiotherapy for cancer patients can produce SJS10. more chances are there if the same patient is under treatment with anti-seizure medications like phenytoin, phenobarbital, and carbamazepine. Usually the SJS10 like lesions for radiation-induced SJS10 lesions will be limited to the area of radiation rather than extensive epidermal involvement. Oh, and in more than one-third of the SJS10 cases, no cause can be identified. One of the some rarely reported causes can include vaccination, systemic diseases, ingestion of contrast medium, external chemical exposure, herbal medicines, and foods. Coming to risk factors, the primary risk factor for SJS10 is active HIV infection. Increased risk of drug reactions and a 100-fold risk of SJS10 is associated with the HIV patients. Malignancy and malignancy, especially active cancer patients, are another risk factors, and genetic factors. The risk of drug-induced SJS10 has been associated with the genetic factors with certain HLA types. Other factors can also be high dose of medications, SLE, physical stimuli like ultraviolet light or radiation therapy on the skin. The clinical presentation for SJS10 patient can very much varied in severity, but almost everyone will have initial phases of prodromal symptoms like fever and mucocutaneous rashes. The fever like influenza-like symptoms usually precede 1 to 3 days before the development of rashes. So early diagnosis or early catching of this disease is utmost important. Photophobia, conjunctival itching or burning, and pain on swallowing may be early symptoms of mucosal involvement. Malaise, myalgia, arthralgia are all present in most of the patients. In some patients, and erythematous eruption can be the heralding sign of SJS or 10. Signs and symptoms that should alert a clinician for the possibility of SJS10 include a fever more than 100.4 degree Fahrenheit, mucositis with skin tenderness and blistering. The acute phase lasts for 8 to 12 days and is characterized by persistent fever, severe mucous membrane involvement, and epidermal sloughing. Re-epithelialization may begin after several days and typically requires 2 to 4 weeks for full re-epithelialization. Now, coming to the cutaneous lesions, these lesions typically begin as ill-defined and start coalescing, and it will look like erythematous macules with the purpuric centers. Many cases of SJS10 may present with a diffuse erythema all over the epidermis. The skin is often tender to touch, and skin pain can be prominent and out of proportion to the clinical findings. Lesions usually start on the face and thorax before symmetrically spreads to other areas of the limb. Scalp, palm, and soles are usually spared. Atypical target lesions with the darker centers may be present. As the disease progresses, vesicles and bullae form, and within days the skin begins to slough. Nikolsky sign, that is the ability to extend the area of superficial sloughing by applying lateral pressure on the surface of skin at an uninvolved site, can be positive. Basically, if a patient's with the SJS10 is there, usually with 10, if in an area of skin where there is no bullae or blisters, if we exert a lateral pressure on the surface of skin, it can induce sloughing, even though visually the area looks like it is unaffected. That is known as Nikolsky sign. Then Asbo-Hansen sign or bulla spread sign is similar. It means that if you exert lateral pressure over a bullae, you can extend the bullae's area by involving the nearby unaffected skin areas. The ultimate appearance of SJS10 patient is linked similar to a patient having extensive thermal burns. Now, these are some of the pictures that show how SJS10 can present. The first two are classical presentation of SJS. You can see severe mucositis of the oral cavity with multiple ulcers and mucositis features. Along with that, multiple small bullae are there, multiple small, not big enough, but coalescing, and there is erythematous rashes all over the body. Now coming to the second two pictures, you can see extensive involvement. Now the bullous size has significantly increased rather than in comparison to the SJS, and there is diffuse erythema all over the body, and this is what we call as a skin sloughing off. You can see the exposed dermis over here with multiple areas of skin sloughing over this patient's back. And this sign is basically, you can see with this skin, this area was not at all exposed, but on applying lateral pressure, the skin moves along and sloughs off, revealing the underlying exposed area. That is Nikolsky sign. Now, continuing with the clinical presentation, mucosal lesions occurs in 90% of cases and can precede or follow skin eruptions. Painful crusts and erosions may occur on any mucosal surface, but usually it affects the oral and ocular surfaces. In women, it can even affect the vagina and vaginal area also. The oral mucosa and vermilion border are most commonly involved with painful hemorrhagic erosions covering with a grayish-white membrane. Ocular presentation is seen in about 80% of patients. The most common change is severe conjunctivitis with purulent discharge, but bullae can develop over the conjunctiva. Corneal ulceration is very frequent, and anterior uveitis or panophthalmitis can also happen. Pain and photophobia are the main presenting complaints for the patient. The eye changes may regress completely, but in at least 50% of patients, there will be late eye sequelae, including pain, dryness, scarring, with the development of synecdoche between the eyelids and conjunctiva. Urogenital manifestations can be seen in 2/3 of the patient and may lead to acute urinary retention. Genital erosions are very frequent. In women, vulvovaginal involvement may present with erosive and ulcerative vaginitis, vaginal vulvar bullae, vaginal synecdoche, and may lead to long-term anatomical sequelae, including labial and vaginal adhesions, stenosis, obstructed urinary stream, and urinary retention. Recurrent cystitis and even development of hematocolpos can be seen in post-SJS or 10 survivors. The pharyngeal mucosa is affected in most of the patients and can present with the dysphagia and odynophagia, but usually tracheal, bronchial, and esophageal membranes are less frequently involved, and intestinal involvement is very rare. Now coming to clinical presentations, complications that can be seen as clinical presentations. In severe cases, the most common complication that we see is fluid loss through the denuded skin. So patient can be severely dehydrated, patient can even go into hypovolemic shock, can go into renal failure and electrolyte imbalance. Bacteremia is second most important complication that we have to look for, since exposed skin is there, it's a breeding ground. Staph aureus and Pseudomonas aeruginosa infections have more risk, and this risk is more associated with 10 and people older than 40 years of age. Pulmonary complications like pneumonia, intestinal pneumonitis with the risk of progression to ARDS, and up to 25% of patients might require even mechanical ventilation. Most common GI complications are diarrhea, can present with melena, small bowel ulcerations, colonic perforations, and small bowel intussusception, but these are very few and rare in comparison to the other complications. DIC can be present in such patients, is strongly associated with increased risk of GI bleeding, and can also be seen with a multi-organ dysfunction, and high probability of death and morbidity is associated with the DIC. Now, how to evaluate a patient who presents with SJS10? Basically, there is no universally good diagnostic criteria, but there are certain things that we can look into, like a suggestive history of drug exposure with a high-risk drug, with febrile illness history, a prodrome of acute febrile illness with malaise, a painful rash that progresses rapidly with skin tenderness, erythematous macules, targetoid lesions, or diffuse erythema progressing to vesicles and bullae. A positive Nikolsky sign or bulla spread sign is highly sensitive. Oral, ocular, and genital mucositis with painful mucosal erosions can point towards SJS10, and necrosis and sloughing of epidermis of varying degree can be seen. Assessment of drug casualty, early withdrawal of the offending drug is very much required. The most common laboratory investigations that we have to do is basically a complete heme panel to check for anemia and lymphopenia, which are common. Eosinophilia is unusual, and neutropenia is present in about 1/3 of patients. Hypoalbuminemia, electrolyte imbalance, and dehydration are very common because of the sloughing of skin and exposed skin. There will be increased BUN and creatine, since there will be increased, there can be rhabdomyolysis and increased cell death, and the patient can also have increased blood glucose levels. Overt hepatitis occurs in very less amount of patients, like 10% only. Bacterial and fungal culture should be performed from blood, mucosal lesions, as well as skin wounds. In children, PCR and serologies for Mycoplasma pneumonia can be done if you are suspecting Mycobacterial pneumonia to be the reason for SJS10. A chest radiograph should be taken in all patients for a baseline assessment and to rule out ARDS. Skin biopsy for confirmation can be obtained but is not mandatory, and dietary immunofluorescence test will usually be negative. The severity and prognosis of SJS10 depend upon the amount of skin detachment or skin with positive Nikolsky sign in comparison to the body surface area. Prognosis can be rapidly evaluated in early stages by applying the scoring system called Scroton. Scroton is based upon 7 independent and easily measured clinical and laboratory variables and has been validated for use on days 1 and 3 of hospitalization. Referral to intensive care therapy or burn unit should be made on a case-to-case basis by the doctor. Severe disease, skin detachment more than 30, that is 10, or a scroton showed more than 2 should be taken as indicators for referring the patient to a intensive care unit or a burn unit. Coming to the differential diagnosis, there are multiple differential diagnoses, but one of the most common differential diagnoses that we have to keep in mind are erythema multiforme. It can be associated, it is usually associated with a HSV infection in 90% of cases and is very rare with drugs. They also present with the typical target lesions or raised atypical targetable lesions, but usually located on extremities, sparing the face and trunks. Bullae and epidermal detachment are usually less than 10% only in erythema multiforme. Erythroderma and erythematous drug eruptions can be also a differential diagnosis. They are generalized and symmetrical maculopapular erythema of a drug eruption, but lacks mucosal involvement and prominent skin pain as like SJS10. Acute generalized erythematous pustulosis is a severe case, and in those severe cases it can be very difficult to differentiate. The acute generalized erythematous pustulosis typically develops within a few days of exposure to the offending drug, often a beta-lactam antibiotic, and resolves within 1 to 2 weeks of this drug discontinuation. Staphylococcal scarlet skin syndrome is a very important differential diagnosis in ED and can be caused by epidermolytic toxins, usually seen in neonates and young children rather than in adults. Generalized erythema rapidly followed by development of flaccid blisters and desquamation are the classical findings. Coming to the treatment of SJS10, supportive care is the mainstay of treatment. The main principles are similar to that of for major burns, include wound care, fluid and electrolyte management, nutritional support, temperature management, pain control, and monitoring and treatment of superinfections. Wound care, mainly the extent of superficial dermis detachment should be assessed every day, and certain centers surgically remove the necrotic epidermis, and certain centers do not remove and use the same dermis over the exposed skin as biological dressing. Non-adherent nanocrystalline gauze materials are replacing the petroleum impregnated gauze for covering the skin. Biosynthetic skin substitutes are now available, and fluidized earbuds are useful when patient's backside is significantly affected. Now coming to fluids and nutrition, imbalance occurs due to the increased water loss from the exposed dermis. Unlike in burns replacement, the total fluid replacement needed is 1/3 of that of severe burns. Room temperature should be increased to 30 to 32 degrees to prevent excessive caloric expenditures. Heated air body warmers can be used. Oral feeding or feeding through nasogastric tube should be started as soon as possible and continued throughout the acute phase of SJS-10. Passage of NG tube should be performed with great care to minimize affected mucosal involvement in the esophagus. Pain control in SJS-10 is another mainstay of treatment. Cutaneous pain is most commonly seen in almost all patients and can be overt than the clinical manifestations. Pain control is also necessary during the wound care procedures. Mild pain less than 4 can be treated with non-opioid analgesics, but opioids should be given for severe pains of pain score more than 4. IV route is the safest and easiest way to achieve faster pain control and to titrate according to patient's needs. Significant care should be taken to prevent infections on patients. High risk of infection and sepsis remain the most common cause for death. However, prophylactic systemic antibiotics is not recommended in any of the guidelines and is not advised. Instead, main management is sterile handling and give reverse isolation procedures. Antiseptic solutions containing octinidyne, polyhexanide, chlorhexidine, or silver nitrate preparations can be used. Silver sulfasalazine should be avoided since SJS can be triggered by sulfasalazine. Repeated culture of skin, blood, catheters, and gastric and urinary tubes should be obtained at 48-hour intervals, and antibiotic of choice should be based upon specific culture data. The prevention of vulvovaginal sequelae is very important in SJS-10 affected women. Early gynecological examination should be performed in all female patients with SJS-10 with any signs of or symptoms referable to these sites. Goal of treatment is decreasing the formation of adhesions and labial agglutination as well as preventing vaginal adenosis. Preventive strategies include application of intravaginal corticosteroids and menstrual suppression during the acute phase of illness. Moderate potency topical steroids can be applied twice a day in patients with ulcerative lesions until resolution of acute phase of illness. Ointments are preferred over creams. Topical antifungal creams can be used in conjunction with the topical corticosteroids to prevent vaginal candidiasis. Now coming to ocular management, baseline ophthalmology consultation should be taken as soon as admission. Ophthalmic manifestations can evolve quickly within the first few days of illness, and daily evaluation and aggressive ophthalmic treatment are indicated. The examination should include fluorescein staining to see corneal or conjunctival loss of surface epithelium. Severity can be graded with a simple score 0 with no ocular involvement, 1 mild with conjunctival hyperemia, 2 severe with either ocular surface epithelial defect or pseudomembrane formation, and 3 very severe where both ocular surface epithelial defect and pseudomembrane formation is present. Saline rinses can be used to clean eyes and eyelids and remove mucus and inflammatory debris. For patients with grade 0, multiple daily lubrication with a preservative-free eye drops can be given. For patients with conjunctival hyperemia, that is grade 1, topical steroids and broad-spectrum antibiotics, moxifloxacin should be applied 4 to 6 times a day along with lubrications. Grade 2 and 3, extensive sloughing of the bulbar conjunctiva and pseudomembrane formation. In addition to above methods, amniotic membrane transplantation performed within 7 to 10 days might prevent loss of visual acuity and cicatricial sequelae. Multiple procedures may be required for such patients. There is scarce and conflicting evidence regarding use of systemic steroids in halting ocular damage and improving visual outcome. Coming to systemic corticosteroids, they are not properly evaluated in clinical trials and remain controversial about the usage. Theoretically, increasing the risk of sepsis, protein catabolism, decreased rate of reepithelialization, restrict their use theoretically, and they are not clearly recommended. There are certain studies that, including a large multi-center European study and meta-analysis, that suggested that a very early treatment of moderate to high dose of steroids, for example, like methylprednisolone, 1 to 2 mg per kg for 3 to 5 days, may not be the harmful and can even be beneficial if given as early as 24 to 48 hours. But subsequent certain studies and a more mortality register mortality analysis study didn't show any benefits. There are also uncertainties regarding specific treatment modalities, that is, whether a high dose or low dose should be given, or should pulse the patients, and treatment timing of and duration of steroids also is uncertain, and it's not clinically proven till now. Coming to cyclosporin, there is increasing evidence that cyclosporin given at 3 to 5 mg per kg per day may slow the progression of SJS10 in the absence of significant toxicity. Intravenous immunoglobulin is not recommended as per the current studies and guidelines, since there is little evidence to support. IVIG adverse effect include renal, hematological and thrombotic complications. Severe hemolysis and nephropathy have been reported in SJS10 patients treated with IVIG. Coming to prognosis, overall mortality rate with SJS10 is approximately 25%, ranging 10% for SJS and more than 30% for 10, and reaching as high as 50% for 10. Mortality is considerably lower in children, ranging from 0 to 9.5% only. Recurrence can be present if re-exposed to the offending drug. Recurrent episodes due to structurally unrelated drugs or infectious agents have also been reported. Now coming to the long-term sequelae following SJS10 infection. SJS10 manifestations, cutaneous, very common, and include hypo or hyperpigmentation, scarring, telogen effluvium, and chronic pruritus. Chronic pain and mucocutaneous sites of involvement have been reported in 1/3 of patients. Ophthalmologic is the most common, with around 50 to 90% of patients having the long-term sequelae with acute ocular involvement, including dry eye, photophobia, tracheasis, neovascularization of cornea, keratitis, symblepharon, corneal scarring, and even visual impairment. Urogenital, especially vulvovaginal and urinary sequelae, include labial agglutination, intraovital stenosis, vaginal dryness, dyspareuria, urinary retention, and formation of hematocolpos. Vaginal adenosis has also been reported. Pulmonary complications include chronic bronchitis, bronchiolitis with obstructive changes, including bronchiolitis obliterans organizing pneumonia or BOOP, and bronchiectasis. Psychological and psychiatric manifestations are also very common, including anxiety, depression, and decreased health-related quality of life. In summary, SJS or 10 are severe mucocutaneous reactions, most commonly triggered by medications, characterized by extensive necrosis and detachment of epidermis with mucosal involvement. Overall mortality rate among patients with SJS10 is approximately 25%. Drugs are the leading cause, with a reaction onset of reaction within 4 days to 4 weeks from the first continuous use of drug. HIV patients, active malignancy patients, genetic predisposition patients with HLA types, SLE remain high risk factors for SJS10. SJS10 can be suspected in case of a fever more than 38 degrees Celsius, with mucositis, skin tenderness, and blistering with a drug exposure history. The scoring system used for prognostication is called as Croton score. Treatment is based upon usually supportive care similar to extensive thermal injuries. Corticosteroids are not advised for severe disease because it's not clinically proven. Cyclosporin can be used safely if there is no toxic effects at the dose of 3 to 5 mg per kg per day. And long-term sequelae are very common and has to be addressed and educated to the patients, bystanders, as well as the patients.